Okey, semua dah ada dah?
Rasanya dah kot.
Tengok, berapa orang you semua?
9.
11 lebih. Okeylah, bolehlah.
Assalamualaikum warahmatullahi wabarakatuh.
Hidayah ya?
Yes. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Hidayah binti Ikma and I will present to you about nebulizer and MDI procedure presentation. So first I will present about the nebulizer. So what is nebulization? Nebulization means administering drugs by inhalation which are dispersed via an aerosol spray, mist or powder. And nebulizer is a device that converts liquid into aerosol droplets suitable for inhalation. So for the indication of the nebulizer, first to treat acute asthma attack, second COPD, and the third one to treat infection by administering antibiotic or antifungal in some cases such as cystic fibrosis, and next one is to aid expectoration by inhalation of hypertonic saline to increase clearance of bronchial secretion. Next, medication prescribed for nebulizer. There are 4 types. First one is bronchodilator. We give the patient salbutamol for acute exacerbation bronchial asthma, acute exacerbation COPD, and severe asthma. Next one is corticosteroid. We give the patient beclomethasone for severe asthma. Next one, anticholinergic. We give the patient ipratropium bromide, same condition as bronchodilator types. And the last one is antibiotic. We give the patient tobramycin, colistin, and aztreonam. We give to the patient who have chronic purulent chest infection. So basic component for nebulizer. First, the machine, mask and mouthpiece, and the Mason-Likar for to put the liquid drops, and last one hose. So there are 2 types of nebulizer, which mask and mouthpiece. First, mask. It is for the children who cannot hold the mouthpiece well. So this mask is easier for the patient to use, but it a little bit uncomfortable. So we must seal tightly the mask so to reduce risk of medicine leak. And the next one is mouthpiece. For patients who have no issues holding the well in the holding the mouthpiece well in their hand, and it requires the person to breathe deeply through their mouth and out through their nose, and there is no leakage of nebulized drug solution, so there is no deposition into nasal passage and mouth if we use mouthpiece. So for the procedure of the nebulizer with spacer, I think there is one slide is missing.
Slide missing. Macam mana missing?
I can I don't know. But yes, this one. I hope.
Position the student while attempting to provide him or her with as much privacy as possible, given the urgency of the situation. Explain the procedure to the student at his or her level of understanding. Encourage the student to assist in the procedure as much as he or she is able to help them learn self-care skills. Review the individualized health plan and or the healthcare provider's orders. Wash your hands. Set up and plug in the nebulizer machine in a location where the power source is close to a comfortable location for the medication to be administered. Follow the directions for the specific brand of nebulizer machine and cup. Unscrew the top of the nebulizer cup. Add medication into the bottom half of the nebulizer cup. Screw the top of the cup back on. Attach the tubing from the cup to the nebulizer machine and the cup onto the face mask or mouthpiece. Place either the face mask on the student or have the student put the mouthpiece in his or her mouth. Turn on the machine. A mist of medication should rapidly appear. Instruct the student to take normal, slow, deep breaths. Be sure to keep the nebulizer cup in an upright position. The cup may require some tapping on the sides towards the end of the treatment to optimize the completion of the dose. The treatment is complete when there is no more mist coming from the cup. This usually takes 10 to 15 minutes. Turn off the machine. Remove the mask or mouthpiece. Rinse the nebulizer cup, the mouthpiece, or mask under warm water. Shake off the excess water. Place on a paper towel to dry. Wash your hands. Document the intervention and outcome in the student's healthcare record. Update the parents and healthcare provider if needed.
Okay, so that's the video for the procedure of the nebulizer. So, okay, so the procedure, I will now explain about the procedure as I have shown you about the video. So you can read after this presentation. So for the side effects, I will explain about the side effect of the drug itself. So first one is salbutamol inhalation. The patient may be experience palpitation, anxiety, mild tremor, hypertension, and headache. And for anticholinergic inhalation, the patient might have blurred vision, confusion, dry mouth, constipation, nausea, and dizziness. So we move to the next one, MDI, which means metered dose inhaler. So MDI is a device that used to deliver a specific amount of medication to the lungs in aerosolized form. It used to when for asthma, COPD, and other respiratory conditions. There are two types of inhaler. The first one is reliever to relieve sudden asthma attack. So we give the patient salbutamol inhaler. And next one is preventer to reduce swelling in the airway and asthma attack. And we give the patient beclomethasone inhaler. So MDI with spacer. So what is spacer? Spacer is used to improve drug deposition into the lung. A spacer can slow down the drug delivered by MDI into the lung. This is for the child who have full coordination to push the canister down and breathing in deeply. So it is recommended for babies and young children. So according to the pediatric protocol, the children who are age under 8 years old can use MDI with spacer and mask, and for children who are 8 years old and above, the patient can use MDI spacer with mask, MDI spacer with mouthpiece, and dry powder inhaler. So I will show you the procedure of the nebulizer with spacer and mouthpiece.
A lot of medicines come in a metered dose inhaler, also called an MDI. Always use these medications with a valved holding chamber called a spacer. There are different types of spacers. Follow the instructions provided with your spacer. Remove caps from the spacer and metered dose inhaler. Shake the MDI for 3 to 5 seconds before using. Spray the MDI no more than 4 times before using it for the first time if you haven't used it in a while or if you dropped it. This is called priming the MDI. Insert the opening of the MDI into the rubber-sealed end of the spacer. Stand or sit up straight. Breathe out completely. Put the mouthpiece between your teeth and make a tight seal with your lips. Make sure your teeth and tongue are not blocking the mouthpiece. Press the top of the MDI so it sprays into the chamber. After spraying the MDI into the valved holding chamber, breathe in slowly and deeply. Hold your breath for 10 seconds, then breathe out normally. Only press 1 time. Wait 1 minute and repeat as prescribed for a minimum of 2 puffs. If you hear a whistle, you are breathing in too fast. If the medicine is an inhaled steroid, have your child rinse his or her mouth and brush his or her teeth after each treatment. Make sure you rinse and spit and don't swallow.
Okay, so this a procedure of the okay. This is the summary of the video. Remove the cap, and then insert the inhaler into the spacer. Breathe out all the way, and press down on the inhaler and slowly breathe in and hold your breath, and count to 10, and slowly breathe out. So for the spacer device care, we must clean the spacer once a week. So take the MDI adapter off the spacer. Do not take off the mask or mouthpiece. Soak the adapter and the spacer in the lukewarm water with mild dish detergent. Do not use hot water or harsh detergents such as chlorine to clean the spacer, as this will damage the spacer. And rinse both parts in clean water. Stand the spacer up in upright position and let it air dry. And caution, do not rub the internal surface of the spacer with brush or cloth, as it will damage the surface of the spacer. And the spacer should be replaced at least once a year. So for the side effect, the doctor must explain the side effects of the medication to the patient's guardian first. So the patient may experience palpitation and tremor, as salbutamol can cause tachycardia and tremor, particularly at higher dose. And the second one is oral thrush. This is what oral thrush is like. Uh, because steroid inhalers can cause candidiasis, and this is for the patient who doesn't wash their mouth out effectively after its use. So thank you. Any question?
Okay, satu, dalam hospital kita pakai oksigen ya, kita tak pakai yang apa tu, mesin nebulizer tu. So for oxygen you have to pakai some more than 6 liter of oxygen. Nombor 2, you have to dilute nebulizer to 4 cc. Dilute to nebulizer to 4 cc. Satu, nombor 2. Okay, MDI kita punya MDI kita tak tahan breathing, kita nafas macam biasa saja. Kita pakai air chamber, kita pakai optic diamond tu, and then kita goncang dulu, spray tu nafas 5 kali. Kalau less than 10 tu kita kira 10, more than tu kita nafas 5 kali. Kita banyak pakai mask, kita jangan pakai tunjung tu. And then kita kena goncang setiap kali, because most medication you want to shake first before you use it. Okay. And then that's it lah. Goncang nafas 5 kali. Tak payah tahan. Tak payah tahan, nafas biasa 5 kali. 5 kali. Teknik kita berbeza sikit daripada apa tunjukkan kat situ. Okay. Please
Terima kasih,
refer to
Doktor.
our protocol and also our ni. Tengok ni cara kita pakai tak sama semua tempat pakai. Next. Next presenter.
Yes, Doctor.
Akila.
Ya, betul.
Topik.
ECG. ECG.
Okay.
Alright. Assalamualaikum warahmatullahi wabarakatuh. Okay. My name is Nur Akila binti Ismail. I'm going to be continue on presenting the procedure presentation on electrocardiogram ECG. So this is my presentation outline. I'm going to be talking about the introduction, indications and contraindications, the procedure and complications. So a bit on the introduction. The standard ECG records the potential difference during the different stages in the cardiac cycle, and it actually reflects the differences in the transmembrane voltages during the depolarization and repolarization within each cycle. So for the standard 12-lead ECG, 10 electrodes are required, 4 electrodes on all the 4 limbs labeled as RA, RL, LA, and LL. As for another 6 electrodes on the chest labeled as V1 until V6. So the resulted 12 leads are 3 bipolar limb leads, lead 1, 2, and 3, and 3 unipolar limb leads, AVF, AVR, and AVL, and 6 precordial chest lead, V1 until V6. So the indications, so basically we need to get 12-lead ECG on any pediatric patients who presented with this, any of these signs and symptoms, which include loss of consciousness or seizures, drug ingestion or other poisoning, chest pain on exertion, any known cardiac history or familial history of sudden cardiac death, dysrhythmia, and cyanosis. As for contraindications, actually there is no absolute contraindication because the standard 12-lead ECG is actually relatively very safe, but we might want to consider if the patient is having any allergies or sensitivity toward the adhesives on the lead. Next here, of course, we're gonna have to start off the procedure with some basic preparation, like obtaining consent once the procedure has been explained to the patient, and then patient positioning, which is preferably in supine position, and we have to clean the skin, which may include washing the area with a mud soap or with an alcohol wipe. And then we can proceed with the electrode placement. We can start with the limb leads. As you can see, there are 4 electrodes, right forearm proximal to the wrist here, LA at the left forearm proximal to the wrist, RL at the right lower leg proximal to the ankle, and LL at the left lower leg proximal to the ankle. So this is the common limb lead placement for both adults and pediatrics. But we do have another option, which is the Mason-Likar lead placement for the limb electrode. As you can see in this picture, the 4 limb electrodes are placed on the limbs near the shoulder and hips. So basically, this method can be used to reduce the muscle movement artifact in order to get a more accurate ECG reading. Proceed with cordial test lead. There are 6 electrodes, V1 at the fourth intercostal space at the right sternal border, V2 at the fourth intercostal space at the left sternal border, V3 at the, actually you can put the V4 first, at the 5th intercostal space at the mid-clavicular line, and then you can put the V3 midway between V2 and V4, and then V5 and at the anterior axillary line at the level of V4, and V6 at the mid-axillary line at the level of V5. And because the right ventricle is more dominant in infants and toddlers, then there is an optional placement of V3R or V4R, which is the same as V3 and V4 the right side. So in order to do this, you can do a separate ECG, or you can just use the V3 wire, but you label it as V3R or V4R and skipping the V3. Okay. So this is how it looks like. You see here the pulsar, and in this you can see all the chest, the precordial chest leads, V1 until V6. So now let us where is the video? Right? Let us take a look at the procedure demonstration.
This is Ella Rose, and today we are performing an ECG. I have already gained consent and have already entered her details into the ECG machine. So now we are going to do some scanning. I'm just feeling her wrist spacings and doing exfoliation on those spaces.
Well,
also exfoliating her wrists, and then I will do her ankles.
and this one, and I'm just going to do your ankles as well, okay?
Now we're just going to take the ISO wipes and we're going to wipe over the areas that we exfoliated.
And we're going to do your arms. It smells like glass. It's a glass of wash. Yeah, it does, doesn't it? It's got alcohol. There we go.
So now we are ready to place the electrodes onto Ella Rose.
Yeah, we've tried them before. Yeah, we've tried them before. So I'm just going to feel your wrist again.
The electrodes are placed on the body facing down, just feeling Ella Rose's spaces.
Can I take them off? Yeah, when we're finished you can take them off. Yeah? Yes. Good. So this one is coming where? About
So
here?
on the child, we place one of the electrodes over to the right side of the chest.
And then one comes under your underarm. Just under here. How's that? One more. And
Electrodes on the wrist will then be placed facing down.
And one on the other one. Good job, you're a good helper.
And ankles facing up.
Is it a bit chilly in this room? Maybe the stickers are cold. I didn't want to do this. That's all right. Look at you. You're going to be like a... You are going to be like a movie star.
Now we are going to attach the wires onto the electrodes.
Got the numbers on them? Good. Okay, so let's go.
So
Number
we
one.
just attach them to the electrode, making sure the it doesn't go too far up onto the electrode.
And it comes up to 3, 4. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. You're so good. 6? You look too little for 6. You look about 5.
Just try to keep the wires straight without too many kinks in them.
When is your birthday? I forgot. You forgot. August.
What number?
20th.
20th. Ooh, that's still sunny. So Ella Rose, in a minute, I'm going to get you to lay. So now we have all the electrodes on. We're going to instruct the patient to lay nice and still, no talking or moving for a moment. And we just cover her up to maintain her dignity. When she's laying nice and still, we have a nice clear trace, nice steady heartbeat, we're going to start. No, there's not letters inside the body. Now we've got the trace. Well done. We unclip the wires from the electrodes, pull the electrode off, stick them to the glove on the back of the hand. This one. Here. That one's a little sticky, isn't it?
Ow.
Ouch, lucky you're not hairy.
Ouch.
Ouch. Ouch.
Last
Last one. Good girl. I'm going to slide them out of there. Good girl.
Okay. So now, okay. So next complication, the last part. Like I said before, the standard 12-lead ECG is relatively safe. It is a routine procedure without any risk or complications, but as the possibility of allergic reaction can be prevented if you take a good history before you start the test. So these are my references. That's all from me. Thank you.
Okay, next.
Sabar je, sorry je.
Ewan, Daniel.
My name is Muhammad Daniel Afif.
Ya?
Muhammad Daniel Afif.
Daniel Afiq.
Yes.
Daniel Nazri ke Daniel Afiq?
Daniel Nazri, Muhammad Daniel Afif bin Muhammad Nazri.
Afif. Topik you?
Central venous line insertion. Can you guys see my screen?
Nampak.
Nampak Sorry.
Siapa yang jaga slide?
Me myself. Boleh nampak slide?
Kecilnya. Dia pakai apa, handphone?
Sebab laptop tak boleh guna. Is it okay now?
Okay, this one better. Okay.
Okay. So my name is Muhammad Daniel Afif bin Muhammad Nazri, and I'll be presenting about the central venous line insertion. And this is my outline for my presentation, which I'll be explaining about introduction, indication, contraindication, equipment, and briefly about the procedure, also about the complication assessment, and also the documentation for central venous line insertion. Okay, so for the introduction, there are many types of central venous access device, and one of them is CVC, which is the central venous catheter. It is also known as central venous line, or central venous access catheter. So it is placed into the large vein, and it is placed into the large vein, such as into the internal jugular vein, femoral vein, and also subclavian vein. Is the placement of this catheter is usually placed into the most centrally located veins, and it is often needed in critically ill patients or also in those patients who require a prolonged intravenous therapy. And PICC, IAP, UAC, and UVC are other type of central venous access. So next is indication for this procedure is mainly it is used to draw blood from patient, and also it is used to administer medication that requires central access such as amiodarone, inotropes, and also high concentration of electrolytes. And it's also used to balance the fluid in monitoring with CVP and also intravenous access, and also to provide the long-term infusion therapy when peripheral access is unavailable. And next is contraindication for this procedure is that, as we all know, there is two kind of contraindication, which is relative and absolute. Relative is when the benefit is more than the risk. So the contraindication is when there is an obstruction of the vein by tumor or mass, and also abnormal vessel and local infections, and the raise in intracranial pressure. As we all know, the IJV is located closely to the head, and the ability to achieve the same objective with a peripheral line, and also if there is a bleeding and coagulopathy disorder on cooperative patients, and also lack in consent in an emergency setting. And for the absolute contraindication is that it is when there is an infection of the overlying skin or soft tissue, or when there is a thrombophlebitis. And next is the equipment for this procedure is that first we need to have ultrasound and sterile ultrasound sheath, the sterile trolley, field gloves, gown, and mask for the doctor and nurses, and Saldinger, central line kit, saline flush, chlorhexidine for the antibacterial solution, and also lidocaine for the and lidocaine sutures, couples, trading, also pressure bag to attach for the monitoring of CVP. And next is, as I've mentioned before, CVC can be inserted at the femoral, subclavian, and also internal jugular sites. So I'll be explaining briefly about these sites. So for the first approach is at the IGV. This is the most common sites for the central venous access. We usually do it at the right side, and it is the closest site from the right heart, and the patient need to be set at the Trendelenburg position, which is 10 to 15 degrees. This is when we lower the level of the head and elevate the feet so that the venous pressure is increased, there is more blood into the vein, and the head is rotated slightly to the left so that it can be easier for the doctor to puncture the vein and at the apex of sternocleidomastoid. So there is three types of approaches at IJV, which is the central, anterior, and also the posterior. And the second one is subclavian approach. We do it at the right side, and we also need to set the patient into the Trendelenburg position. The head is neutral as it is quite far from the head, and it is located inferior to the clavicle. And the third one is the femoral approach. It is a rare occasion for using this site, but we can use the femoral site when we want to do a temporary hemodialysis of paresis catheter, and also
common in children common.
Or did this
They are more use in children use femoral more than the
subclavian?
Subclavian in children.
Okay.
Because children is difficult to access subclavian.
Okay, thank you, doctor. And
Continue,
Okay,
huh?
and there is also an accessibility of other primary central veins and also doing cardiopulmonary resuscitation. And when we do this kind of approach, the patient need to be in a supine position, and we need to pulse for the femoral artery, and we will find the femoral vein medial to the femoral artery. And next is the advantages and disadvantages of all these approaches. Basically, for the IGV, the advantages is the bleeding can be controlled and the malposition is rare as we use the ultrasound to help with the puncture. And disadvantages is the risk of carotid artery puncture, and pneumothorax is also possible even though the risk is quite low. For the subclavian, the advantages is the most comfortable for the conscious patient, and disadvantages is it has a high risk of bleeding, and it also has the highest risk of pneumothorax as the site of puncture is closely related to the apex of the lung. And the third one is femoral. It is quite easy to find and no risk of pneumothorax, but it has a highest risk of infection and also the risk of DVT. And next, I'll be explaining about the procedure. Uh, I will not explain that much because I will just show you guys a video. Can you guys see the video? Okay, so basically after the sutures done, they did a cleaning to the suture side, and also they put a bandage on the puncture side. Okay, next we will go to the complication. So there is many complication for this procedure, and there is infection, especially from the staph epidermidis and staphylococcus aureus. Also, there can be a hemothorax and pneumothorax, as I mentioned before. There can also be a hematoma, air embolism, and dislodgement of thrombus and a central line catheter. So for the assessment and monitoring, we need to monitor ease or difficulty with obtaining a blood return and monitor for any arrhythmia. So for the arrhythmia, this can happen when the wire it enters through the heart. And for the last but not least is documentation. Is for the indication for procedure, we need to take the date and time and the appearance of the insertion site. And we also need to tell the patient about the type, size, and position of the central venous line and medication given through the central line, and also note the adverse reaction of this procedure. That's all for me. Thank you.
Okay. Next.
Saya next. Fawaz Naim, Muhammad Fawaz Naim.
Fawaz, eh?
Okay. Okay, Assalamualaikum warahmatullahi ta'ala wabarakatuh. My name is Muhammad Fawaz Naim bin Kamarizan, metric number 1811253, and I'll be presenting about urinary bladder drainage. So these are my table of contents. So first of all, we go with the introduction. So urinary catheterization refers to the insertion of a catheter tube through the urethra and into the bladder primarily to drain urine. And there are two types of urethral catheterization. One is intermittent, which is single lumen catheter, and the other one is indwelling, which is double or even triple lumen catheter. And indwelling urinary catheters can be inserted either transurethral or suprapubically. So transurethral is when it's going through the urethra, and suprapubically is when the catheter is inserted via the anterior abdominal wall above the pubic bone. So that's why it's suprapubic. So next is indication and contraindication. The
Just boleh
indication
belakang 10 tadi. Good tak? Okay. Okay.
As for indication and contraindication, the indications are to drain the bladder prior to surgery, to measure the urine output, to relieve the retention of urine, to relieve urinary incontinence, and also for investigations such as urine culture. And contraindication is when there are presence of urethral trauma, such as those in pelvic fractures or straddle impact. So the picture shown is a straddle impact. So next is the equipment needed for the procedure. We need sterile and non-sterile gloves, sterile drapes, cleansing solution, cotton swabs, forceps, sterile water, Foley catheter. And as for Foley catheter, the size will depend on the age and also the weight of the patient, syringe, lubricant, collection bag, catheterization kit, and also containers for urinalysis or culture. Before proceeding with the video,
Ni is for bigger children kan?
Yes.
Semua children kita pakai tu je tube feeding ya. Okay.
Okay, before proceeding with the video, this is a brief. Before proceeding with procedure, we need to prepare as we need to gain consent for the procedure. We also need to give a thorough explanation to the family about the procedure, and we need to ensure that the patient privacy is maintained throughout the procedure, and then prepare the equipment. And this is a table for the catheter size depending on the age and also the weight of the children, the patient. Because if it's too small, then leakage can occur. If it's too big, then damage can happen.
Sebelah belakang tadi boleh? Reference umbilical catheter. Yeah. Okay. Okay.
So this is a brief procedure taken from PATS protocol. So first we need to position the child in a forward position, clean and drape the perineum. In girls, we need to separate the labia majora with fingers to expose the rectal opening.
Dah settle dah?
In boys, we need to
Dah.
hold the fingers perpendicular to the body and
Betul,
pass
jangan ada masa buka
the
pintu
urine machine
rumah
and advance a few centimeters further.
kunci.
Then we need to secure the catheter with adhesive tape to the body and connect the catheter to the urine bladder.
Itu ya, dia kalau
This is
hujan dia potong kuat.
catheter insertion in a male patient.
Nah.
Male infant catheter insertion.
In this video, we will demonstrate the technique of inserting a urinary catheter in a male infant. The first thing we must do is to check that we have the correct patient and ensure that we have explained the procedure to the patient or their parents. A sterile field should be set up next to the patient since the catheter is inserted in the sterile condition possible. Supplies should be gathered, and in this case, we should have betadine to provide sterility of the field, the catheter in which you to be inserted, KY jelly as a lubricant to ensure that the catheter easily go through the urinary tract, sterile water to inflate the Foley balloon, and finally some drapes in order to maintain sterility around the area of interest. Procedure first begins with providing drapes around the patient in order to maintain a sterile field. Next, betadine should be amply applied to the head of the penis in order to sterilize the field. Betadine is applied in a circular motion, starting from the center, moving outward. In boys who are uncircumcised, it's advisable to just gently retract the foreskin to the point where the urethral meatus is exposed. Careful attention should be paid to not retracting the skin so much to cause bleeding or injury. If, however, there is physiologic phimosis and the foreskin cannot be retracted back in order to visualize the urethral meatus, the betadine should just be applied generously around the area of catheter insertion. Next, the Foley is then going to be lubricated with KY jelly in this case. Some clinicians recommend inflating the balloon prior to insertion of the catheter to ensure that the balloon will inflate and does not leak. If this occurs, the catheter could accidentally fall out. Others, however, do not routinely practice this since it could cause the diameter of the catheter to be enlarged due to the stretching of the balloon, making it more difficult to insert the catheter. And then, with the left hand holding the penis straight, the Foley catheter is inserted into the urethral meatus. Again, in boys who are uncircumcised and have quite tight foreskin, aiming the catheter at the 6 o'clock position often places it into the urethral meatus without actually visualizing the urethral meatus itself. If any resistance occurs, please stop, reevaluate your situation before attempting another pass of the urethral catheter. As we discussed previously, once the catheter has reached the bladder, urine should flow freely out of the catheter. However, it is not uncommon that the lubrication used for the catheter placement can plug up the opening and prevent urine from freely coming out. Sometimes flushing the catheter with a little bit of water may help begin the process to ensure that you are indeed in. At any time there's no adequate flow of urine from the catheter, then it should be flushed with water easily to confirm that you are indeed in the bladder. Once that the catheter has been confirmed to be in the bladder, the balloon should be inflated, and for most pediatric Foley, around 3 to 5 cc of fluid is adequate. Once that has been done, the catheter can be gently pulled back in order to remove all the excess catheter from the bladder and allowing the Foley to rest securely at the bladder neck. If blood is seen in the Foley, It is important to leave the catheter in position and ask for urological assistance.
Okay, so moving on to the complication of the procedure. So first, urethral injury can occur due to trauma sustained during insertion or balloon inflation in the incorrect position. So that's why it's important to ensure that catheter is inserted in the bladder before inflating the balloon. So next is urethral stricture following damage to the urethra. And infection can also occur. So to minimize infection, we need to use surgical aseptic technique while doing the catheterization. In male patient, paraphimosis can also occur due to failure to return foreskin to the normal position after catheter insertion. False passage can also occur, which means when the catheter is pushed through the urethral wall. And also another complication is hemorrhage. So that's going to be all for my presentation, and this is my references. And thank you.
Okay. Ada lagi?
Tak ada dah, doktor.
Pak ya. Okay.
Doktor nak tanya, pasal markah kami
bagi direct pada tu nanti.
Oh, okay.
9 orang kan? Okay, ha. Okay, ha. 9 orang kan itu kan? Okay, ha. Okay. Bagi direct pada tu nanti. Okay.
Thank you, Doctor.
Thank you, Dato.